Welcome everyone to the Observatorio, the Cervantes Institute in Harvard, and welcome to this Teaching Foreign Languages workshop. This is a new year, this is a new semester, and we have new opportunities to host a bunch of events, workshops and activities regarding the Spanish language, the Hispanic cultures, and in the United States, and also training for teachers. You, I think, all know very well the Cervantes Observatorio. This Instituto Cervantes here and the Faculty of Arts and Sciences at Harvard University created in 2013 this Observatory of the Spanish language. And among other activities, the Observatorio hosts the DELE exams, the Diploma de Español como Lengua Extranjera, and we also organize workshops and courses for teachers of foreign languages, mainly teachers of Spanish, but not only Spanish, and many other activities we are offering for you all along the semester. Let me just mention a few of them. By February 12th, we have a new Teaching Foreign Languages workshop. Is Artful and European Framework Equivalencies by José Ignacio Cayenne, Instituto Cervantes, New York. By on February 25th, we have a presentation of a project called Canary Islander in the USA, Canarios in Louisiana. And on March the 4th, we have a new conversation in the Observatorio about the Spanish in the United States and the Spanish of the United States, by two big names of the linguistics in the United States, Ofelia Garcia and Ricardo Otegui, both from CUNY. So welcome to this Teaching Foreign Languages workshops about Spanish in the health service in the United States. We'll be here until 1:30, more or less, at 11:30, depends of the professor. We have a coffee break for having a coffee, obviously, or some beverages or sandwiches. And by the end of the workshop, we will distribute an evaluation form and a certificate in which you have just to write your names. Our guest today is an excellent expert about Spanish in the United States. He's very prestigious and very well known within this field. Glenn Martínez. Martínez is professor of Hispanic linguistics and chair of the Department of Spanish and Portuguese in the Ohio State University. His research focuses on sociolinguistics and applied linguistics of Spanish-speaking communities in the United States, and also along the U.S.-Mexico border. He has written seminal works in the historical sociolinguistics of Spanish in the Southwest. He has made significant contributions in the area of language policies affecting Spanish speakers. He has also written extensively on the teaching of Spanish to heritage learners, and specifically on Spanish in the health service in the United States. So it is obvious we are lucky for having Glenn Martínez among us today, and I hope you enjoy very much this seminar. So please join me to welcome Glenn Martínez one more time in this observatory.
Thank you. Thank you. Thank you, Paco. Good morning. I'd like to just kind of give you an overview of what we intend to do this morning. So I'm going to focus on various aspects of language and healthcare policy, and I'm going to review some of the research that I've done on language and healthcare policy. We are going to reflect on this policy through narratives of Spanish speakers in the healthcare setting. And finally, I want to take this reflection and see how we can guide it and shape it towards pedagogy, towards teaching, right? So how do we impact and affect the health workforce to improve outcomes and quality for Spanish-speaking patients? So, as I said, my aim in this talk is to provide you with a synthesis of my own research on Spanish in the U.S. health delivery system. And through this synthesis, I hope to share with you my own reflection on policy, as well as my vision for future research in this field. Now, I have to admit that I'm a sociolinguist by training, right? And as a sociolinguist, my interest and my perspective has been on language policies in healthcare. Language policies. So how are these language policies performed? How are they perceived? And how do they impact Spanish speakers? I recognize at the same time, however, that language policy in healthcare really is nothing more than health policy. Language policy is health policy, inasmuch as its main goal is to modulate the distribution and adjust the delivery of care for the purpose of improving health outcomes in patients and in populations. So this recognition that what I have in view in studying language and healthcare policies is about more than language, is about speakers, really, I think, does more than simply direct and orient my approach to the study of language policy in healthcare, but it also, and more fundamentally, shapes my identity as a sociolinguist. Sociolinguistics is the study of the complex and multifaceted relationship between language and society, right? And Ralph Fasold pointed out many years ago that sociolinguistic research and methodology may be oriented towards what he called the sociolinguistics of language or a sociolinguistics of society. In my own thinking about language and society, I've been driven to a further kind of distinction between a sociolinguistics of society and a sociolinguistics of the speaker in society. To study language is really to study the speaker of the language, because without speakers, there is no language really of which to speak. So the study of language and healthcare in general, and the study of language policy in healthcare more specifically, is really a study of what I've called previously language experience. It's a language experience. It is the study of experiences in, around, and through language, and the resulting implications of those experiences on human biology. So given this orientation towards language experience, I want to begin this talk by telling you the story of one such experience. And you'll see throughout the talk that, in fact, the experience and the story is going to be really at the heart of everything that we do. So let me tell you the story of Griselda Zamora. Griselda Zamora was a bright and gifted girl, daughter of two proud parents, Antonio and Inés Zamora. As the daughter of immigrant parents who spoke very little English, Griselda's giftedness was expressed not only in her academic performance in school, but also, as noted by Guadalupe Valdez in her book, Expanding Definitions of Giftedness, her giftedness was displayed in her daily efforts to help her parents navigate the complex and routine affairs of life in a society that does not speak nor accept their language. Griselda would accompany her parents to doctor's visits. She would translate letters from school and work into Spanish. She would answer the phone on her parents' behalf when they received calls from bill collectors and social service agencies. On March 13th, 1999, March 13th, 1999, Griselda came down with abdominal pain, nausea, loss of appetite, and cold sweats. Antonio and Inés, having exhausted all known home remedies and worried about their daughter's grave and deteriorating condition, rushed her to the emergency room at Mesa Lutheran Hospital. There, her condition was evaluated as gastritis, and she was promptly discharged without any treatment. Griselda's symptoms worsened over the next several days, and on March 16th, her parents took her back to Mesa Lutheran. By this time, Griselda's ability to speak was severely impaired. Doctors again diagnosed acute gastritis. Antonio and Ines used whatever English they could muster to communicate with the doctors since Griselda could no longer speak. The doctors prescribed medication and told the parents to see a doctor in 3 days or to return to the emergency room if new symptoms appeared. Antonio and Ines understood that they were to wait 3 days before returning. So on March 18th, exactly 3 days after the ER visit, Griselda was vomiting green liquid, was disoriented, and had lost the ability to speak and walk on her own. Antonio and Ines rushed her back to the ER at Mesa Lutheran. Her condition was assessed and she was transported by emergency helicopter to Good Samaritan Regional Medical Center in Phoenix. 2 hours later, Griselda died. She was 13 years old. The cause of death, a ruptured appendix. The case made national headlines back in '99 and was later, in fact, probed for the possibility of medical malpractice. For policymakers and health professionals, it really sounded an alarm for the need to address language issues in healthcare. Griselda's tragic, untimely, and preventable death really gave way to a series of policies designed to break down language barriers in healthcare and to make healthcare accessible to all, regardless of their proficiency in English. So what you see at the bottom there is a little timeline of language and healthcare policy, and I want to present a brief retrospect of this policy so you have an understanding of what the field looks like. So on August 11th, the year 2000, President Bill Clinton signed Executive Order 13166 entitled Improving Access to Services for Persons with Limited English Proficiency. The executive action required that all federal agencies and organizations receiving funding from federal agencies should develop plans to make services accessible to clients with limited English proficiency. So this was any federal agency that directly provides services, and it was any institution or organization that received federal dollars in any way from grants, from reimbursements, from any other federal source. All were required to develop a plan to make services accessible to clients with limited English proficiency. In 2001, under the leadership of then Secretary of Health and Human Services, Donna Shalala, the U.S. Department of Health and Human Services commissioned the Office of Minority Health to develop a set of standards for health organizations to comply with the executive action. Now, if you think about how much federal money goes into healthcare, you understand the need for specific guidelines for healthcare organizations. Healthcare is funded by the federal government in numerous ways, Medicare and Medicaid being probably the most significant, but also block grants to federally qualified health centers for indigent care, for care for the uninsured, also funding for capital improvements of hospitals and healthcare facilities, also grants for clinical research. So, I mean, the amount of funding going into healthcare from federal sources is substantial. And if, in fact, an executive order would cut off funding, it would be quite damaging to the health delivery system. So the then Secretary of Health and Human Services made this effort to provide guidelines and make it easier for organizations to comply. So this was back in 2001, and the result was the publication of what's known as the National Standards for Culturally and Linguistically Appropriate Services, also known as the CLAS standards. The class standards served as a guideline for hospitals, clinics, and doctors' offices to make their services available to patients with limited English proficiency. It included recommendations and guidelines concerning the governance of the organization, the inclusion of linguistic minorities in the workforce and the leadership of organizations. And more significantly, it set forth 4 language access mandates. And these are the language access mandates that occur within class. So class is actually 14 standards, and these are 4 of those 14 standards. So standard number 1 is that healthcare organizations are to offer and provide language assistance services, including bilingual staff and interpreter services, at no cost to each patient consumer with limited English proficiency, at all points of contact, in a timely manner during all hours of operation. Second, that healthcare organizations are to provide patients and consumers in their preferred language both verbal offers and written notices informing them of their right to receive language assistance services. The third, that they are to assure the competence of language assistance provided to limited English proficient patients and consumers by interpreters and bilingual staff. Family and friends should not be used to provide interpretation services unless that is the wish and request of the patient. And finally, the healthcare organizations are to make available easily understood patient-related materials and post signage in the language of commonly encountered groups and groups represented in the service area. So the class language access mandates likely constitute the most explicit language legislation since the Lau remedies and the beginnings of federally mandated bilingual education. The mandates thus generated a significant amount of consternation among health organization administrators, especially given the fact that they are viewed as an unfunded mandate. Notice number 1, at no cost to the patient, right? Now, what in healthcare, anyone who's been to the hospital or doctor's office recently, what doesn't cost anything? They bill you for everything, right? What does a Tylenol cost in a hospital? It costs like $50. You know, so that this notion of no cost to the patient, I think, really elevated the concern and consternation of healthcare administrators, together with the growing linguistic diversity. So does it mean that they need to have language assistance available in every single language that is spoken or will be spoken or possibly could be spoken in their service region? Right? So this was the concern by the healthcare administrators. And the concerns were addressed not by the Department of Health and Human Services, but rather by the Department of Justice through a guidance statement provided by the Office of Civil Rights in 2005. So the Office of Civil Rights sought to quell the consternation of hospital administrators, healthcare systems, and I might add medical associations, so the AMA, the AHA, right, the American Medical Association, American Hospital Association, all came out and voiced opposition to the class standards because of, you know, the difficulty in actually complying. So what OCR did, the Office of Civil Rights, they proposed what they called a 4-factor analysis that would specify the conditions under which compliance with the mandates would be required, right? So we have these 4 language access mandates, but we apply these language access mandates based on a 4-factor analysis, and these are the Department of Justice guidelines. So they say recipients of federal financial assistance have an obligation to reduce language barriers that can preclude meaningful access by LEP persons to important benefits, rights, programs, information, and services. The starting point is an individual assessment that balances the following 4 factors. 1, the number or proportion of LEP persons eligible to be served or likely to be encountered by the program or grantee recipient, right? So the number or proportion of LEP persons eligible to be served are likely to be encountered, right? If you have a hospital in a place that receives very few speakers of other languages, then you have no reason to comply, right? No responsibility to comply. The frequency with which LEP individuals come in contact with the program, so you may be in Los Angeles, but you have no contact with Spanish speakers, right? So in that case, you would not have to comply, or your responsibility to comply would be lessened. The nature and importance of the program, activity, or service provided by the program to people's lives, right? So if you are an urgent care or emergency room, you're more responsible to comply. If you're a vein clinic or a plastic surgery clinic, then you have less responsibility, right? So what is the importance of the service to people's lives? And finally, the resources available to the grantee, recipient, and cost. So if you have the money to do it, good. If you don't, then you don't have to, right? So what's the effect of the Department of Justice guidance? I think the Department of Justice guidance really took the teeth out of the language access mandates, right? In as much as it restricted language access compliance to the largest organizations providing the most essential of services. Really, it put language access, it limited it and contained it within hospital services, right? In metropolitan areas, in areas with larger numbers of non-English speaking patients. So that was 2005, and we're going to fast forward now to 2010. In 2010, the Joint Commission is the accreditation agency for hospitals and many larger clinics, at least multi-physician clinics and offices normally will seek Joint Commission accreditation. And Joint Commission accreditation is what tells the public and assures the public that your hospital or clinic is safe, right, and meets safety standards, and that the hospital or clinic provides quality services. So the Joint Commission added accreditation requirements in 2010 that mirrored the language of the class mandates within its focus on patient safety and quality of care, right? What this means is that Joint Commission accredited hospitals and clinics that do not follow the language access mandates may in fact lose their accreditation. And this then it puts the teeth back into the language access mandates. People are very worried about, a hospital administrator is very worried about losing accreditation. Just like a university is very worried about losing accreditation, right? So accreditation really it's a voluntary process, but it's a process that demonstrates to the public that your organization is a safe and high quality organization. And the enforcement of these accreditation requirements, therefore, once again elevated concern over language access within Joint Commission accredited organizations. It really became more of a concern because of the way that accreditation works. So a hospital is accredited using two different means or methodologies, right? So survey methodology is where the surveyors, accreditors, will go to the hospital, look at the policy manual, look at the procedures, ask questions of administrators and health personnel. And tracer methodology is another method that accreditors use, in which they'll basically ask for a random sample of charts from the organization's patient population. They'll take these charts and they'll look at every single interaction of the patient with the healthcare organization to see if that interaction met accreditation standards, right? So Juan Sanchez is admitted to the hospital, sees nurse Betty Molina, and the surveyor will ask, well, did Betty Molina have her vaccine shots? Yes. Where are they? Show me the proof, right? And what happens then is that tracer methodology opens up all of these interactions, and accreditors now can ask, right? Well, so patient Juan Sanchez saw nurse Mary Floyd. Does Mary Floyd speak Spanish? Because Juan Sanchez says his preferred language is Spanish. And if Mary Floyd doesn't speak Spanish, then was there an interpreter? Where's the documentation that an interpreter was called, right? So the likelihood of being dinged on these requirements is very, very high. And in fact, we have seen more and more cases in which hospitals are being cited for violating this or not meeting this accreditation standard, right? As soon as they came to be enforced. So I think that the Joint Commission really played an important part in the enforcement of these language access mandates. In 2013, the Office of Minority Health launched the Enhanced Class Standards. And with the Enhanced Class Standards, they reaffirmed the U.S. Department of Health and Human Services' commitment to language access and more explicitly connected language access to effective communication within the health delivery system. Okay, so that is my short retrospect on policy. Any questions or comments thus far? This could be as interactive as you want it to be, so you can just stop me and right if you have any questions.
Well, I have a comment.
Mm-hmm.
Like one of the issues that I noticed in some of the hospitals here is they just have like a red telephone.
Yeah.
So they don't even have personnel, they're outsourcing.
Yes. Yeah. That's very common. That's very common. So telephonic interpreting, video interpreting. There's a system called MARTI that's very common in Ohio. It's basically a cart like this with a computer. Someone connected to the other side, and you cart it into the room, and you got a talking head here, and they'll do the interpretation, right? So, yeah.
And then one more question. I understand now you put the standards here, but my understanding discussing with people at Bay State is that in theory there should be these bilingual interaction at any point from the reception desk to, and obviously they're not doing that.
Yeah, they're not doing that. They're not. No. We're going to talk about that in terms of the kind of research that I've been doing on policy implementation, right? Okay, but yeah, you're certainly right that, and providing patients verbal offers and written notices, not very likely, right? So I mean I think that there's a tendency to be more compliant, but it's not full compliance, and the threat of losing federal funding I don't think was ever a real threat, right? I don't think anyone would be denied a reimbursement claim from Medicare or Medicaid because they didn't follow, some standards. So, yeah. Okay. So, anything else? Any other comments? One thing I forgot to do was to ask you to introduce yourselves to me. So Paco introduced me to you, but I don't know who everyone is. I know Luis because he was my professor at UMass. It's great to see you again. But so why don't we go around and just tell us what your name is and what your background is, either in Spanish teaching or in healthcare and Spanish speakers in healthcare. So let's start with this.
Okay, as you know, I teach at UMass. And as we've been discussing over the phone last week, I think, we are implementing at UMass Amherst a certificate in Spanish for the health professions, working with the School of Nursing. So these brought me to call you and we read some of your articles in my class. I've been also teaching a class where we're working with Holyoke Health, translating their webpage materials and things like this. Sometimes we do the translation, discuss that issue, and we talk about health disparities and then Latinos in Massachusetts.
Okay.
So that's what brought me.
Okay. Iris?
Hi, good morning. I'm Maria Luisa Parra. I'm senior preceptor here at Harvard University. I'm in charge of the first year program Spanish and in charge of the Latino Spanish heritage for Latino students. I'm a psychologist by training and linguist, and I work with families sometimes, and I think that these topics is really interesting. And also, a lot of my students, Latino students, are pre-med, and I really encourage them to, use that, keep that Spanish alive. It's exactly because of the work you're doing. I mean, I think it's fascinating. Thank you.
My name is Maria del Mar. I'm a Spanish teacher here in Boston College and Harvard University with Maria Luisa, sorry. And I'm interested in this topic because I was teaching a class, Spanish for medical purpose in Spain. And then I would like to learn a little bit more.
I'm Francisco Jacobi. I'm with the Mexican Consulate. I'm the Consul for Community Affairs and Protection.
I'm Eva. I came here 2 years ago, 2 years and a half, and I was working in Spain as a translator, and I wanted to work also as an interpreter. So, I don't know, some changes happened in my life, and now I'm here, and I'm working as a medical Spanish interpreter at Bethel Hospital since August, so I'm pretty new in this field, but it's really interesting for me to see, because we have studied this in order to have the medical certificate, so it's good to refresh on that, and it's good also to have your view, and I'm pretty new, but if I can also make a comment, something later.
Okay, great.
My name is Elena Carrion. I also teach at Boston College with Mar, Spanish, and I'm a translator by training, but I haven't had the chance to get into this field.
Okay. Great.
Hi, my name is Pia Cuneo. My background is in law, so that interests me a lot, all the policies. And now I'm teaching Spanish at Boston College and Simmons College with Mar and Elena, right? And many of my students too at Simmons, they're interested in nursing, medicine, sometimes at BC medicine too. So I think this would be very helpful for me, right?
Great.
Hi, I'm Lucia Reyes. I teach at Brandeis University, and I teach 2 classes of Spanish for native speakers and Spanish for medical professionals. It's a small university. It has a pre-med program, so many students take Spanish for medical professions, thinking about the future.
Yeah, good. Let's go back.
Good morning, my name is Kiana Bradero, and today is informational for me because my colleague invited me or sent me the information, so I'm here to learn. So I don't have a whole lot to say because
You're welcome.
My name is Paz Carrasco. I work in clinical research in Kendall, we're in the pharma industry, and I'm from Spain. And I'm very interested, and I'm amazed how the people are working here to maintain Spanish. And my husband is from Austria. I've been living 4 years in Austria, and for me it was very difficult to deal with German. And here I just registered with my family doctor last week, and it was amazing how everything is in Spanish, English. They asked me, do you prefer to fill the form in Spanish, do you prefer in English? And so I think that is a great effort and service.
Yeah, great. Let's go back.
Hi, my name is Tamara. I'm from Spain.
I'm a healthcare professional. I'm a pharmacist, and I'm certifying my degree to work as a pharmacist here. I've been working at Brigham's Hospital for the past 2 years in a specialized clinic, and I was in charge of the Spanish population patients sometimes when I had to cover the person in charge of that. And I noticed a huge misinformation and a gap there with a lot of patients. They don't really know what's their problem, what's the medication for, and I worked with them and I explained, and they were very appreciative of that. And I saw the lack of these professionals, bilingual professionals, to try to make them understand what they have. So I'm very interested in this topic, and I want to work on that in the future.
Great. Welcome.
And he's my husband. He's in the process of learning Spanish.
Okay. Okay.
He came with me just to get more information about it.
Okay.
Hi, my name is Susana Castillo Rodriguez. I'm a teacher at sociolinguistics, St. Anselm College in New Hampshire. And there we have a really solid program in nursing, and next year we are going to start with a minor in nursing and Spanish.
Great.
So this is why I'm very interested in this program.
That's
And my experience is in healthcare and migration in Spain, and I'm here to learn more.
Okay, great, welcome.
My name is Estefania Bralejo. I'm teaching also at Boston College and Emerson. Have been here for years now. My background is more in linguistics and literature, but I'm interested in this field. I don't have any background in the medical studies, but I think it's very interesting the way the service, the application you can do with language, how you can help people.
Yeah.
I'm interested in knowing more about the system.
Okay.
So hello, my name is Siria Dopazo. I'm a nurse by training, but I'm currently a student of a program in transnational cultural and community studies.
Good.
I'm also working in a project funded by the OMAH, and we're working trying to help the pockets of Latinos in Massachusetts that are underinsured or uninsured. So we provide the linguistic and cultural capacity for them
to obtain, the Affordable Care Act insurance. Good, great. Okay, well, good. So let's continue on then with a little bit on the research side. So research on language policy and healthcare. So the background that I just gave you, I hope will be sort of an orientation to this synthesis and reflection of my own research on language policy and healthcare, the majority of which takes place in the border region, right, between Texas and Mexico, Arizona, Mexico border. And I want to summarize some of the major findings in my work and bring to the fore some of the lingering questions that it's generated. And what we'll be doing is, as I present these ideas and findings, I'm going to try to generalize a bit, and then I'm going to show you a story, right? So there'll be another story, and then I want you to reflect on that story to see how we can bring these findings and generalizations into greater clarity and focus through people's experiences, right? So in looking at language and healthcare policy, I've had a great interest in the ideologies of language present in the formulation of policies. So how do policymakers and the practitioners that implement these policies conceive of language and talk about it? What is language for, someone in the health professions who's reading these language access mandates? How are they conceiving of language? How are they thinking about it? How are they talking about it? And this question, I think, increases in importance when we recognize that languages, conceptions of languageness, and meta-languages used to talk about language, following Simfrey Makoni and Alastair Pennicook, are really inventions rooted in colonial and nationalistic projects in different parts of the globe, right? I mean, what is a language? Is Spanish bounded to the countries where it's adopted as official, or is the language more flexible and fluid than that? Why is one particular language associated with one particular geopolitical unit? How did that come about? Was that some miraculous project, or did it have to do with interests and with power and with the ways that geopolitical divisions are made and the reasons that they're made and sustained? So this is Simfrey Makoni and Alistair Pennycook's argument in their book called Reinventing Languages. So this inventedness, I would argue, contributes to a salient disjoint in the discourse of health policy, where language assistance is divorced and disembedded from language acceptance. Okay, so let's kind of unpack this disjuncture between language assistance and language acceptance. I think the disjuncture is evident in the viewpoint of language assistance as an overtaxing burden, as an unfunded mandate that really led to the Department of Justice formulation, as well as in the formulation itself, as it reduces language assistance to only the most emergent cases within the largest and most well-financially resourced organizations within the system. I think the disjunction and the difference between language assistance and language acceptance is also evident in the abjection felt by Antonio and Inés Zamora when they lost their daughter to a highly preventable and curable condition. And it continues to be evident as Spanish speakers encounter hostile reactions to their presence in the health delivery system. I remember in Natalie Kelly's Narrative Matters piece in Health Policy, she's a telephone interpreter, and she recalled in that piece when a physician told a patient that she was interpreting for over the phone, "Next time you come in, you habla inglés, comprende?" So what is the underlying conception of language that drives this wedge between language assistance and language acceptance? In order to get at this question, I conducted a discourse analysis of 3 foundational documents in language and healthcare policy published by the U.S. Department of Health and Human Services. And my intent in doing that discourse analysis was to uncover the particular conception of language and languageness emerging in health policy discourse. The analysis revealed 2 important facets of the invention of language in health policy discourse. First, I found that language was viewed as an autonomous system, this neutral tool used for the accurate and objective transmission or telementation of ideas. And this, of course, is a concept of language that Bauman and Briggs have argued was really a key contour in the voice of modernity. It's a key construct in the construction of modernity, this view of language as neutral, as autonomous, as disembedded and taken away from its, outside of its speakers. So we see this autonomous view of language in these policy documents in statements such as, language is as important a diagnostic tool or more so than any blood test or x-ray, right? So language then becomes a tool, a medical instrument, right? And as a medical instrument, it is open to regimes of surveillance and control that would be applied to any other medical instrument. You know, you have an x-ray machine, you have it checked on a 3-month schedule, right? You have the technician come and check it out and make sure that it's okay and working fine. Well, the same thing happens with language, as it's viewed as a tool, as an instrument, right? So it needs to be controlled, it needs to be surveilled, it needs to be measured, and so forth. So this surveillance and control I think was also evident in the documents analyzed. So notice the second quote that I have here. The hospital had no control over the quality or content of the instructions that patients received. The recommendation is that bilingual clinicians and other staff who communicate directly with patients in their preferred language must demonstrate command of both English and the target language. So there's this autonomous view of language that then leads to these notions of surveillance and control of the language, right, in order to ensure that the instrument is functioning appropriately, okay? So that's one view of language that seems to be implicit in the policy, and that I think contributes to this distinction between assistance and acceptance. So what do you understand? How is the autonomous view of language connected to this distinction between assistance, language assistance, and language acceptance?
One question for me, and I do not know how it works, but how are those certifications handled? Is there like a standardized exam to be qualified, and what is the language used there?
Yeah.
Like so many of my bilingual students who come to UMass and place into Spanish 200, even if they're fluent in the language.
Yeah. Yeah.
Do we have that kind of problem in the certification of medical interpreters?
I think we do. I think we do. And there's actually a study that I'm going to talk about in just a second about how that works. So, yeah, I think that the same standard language ideologies, the same preferences for certain types of language, more written types of languages, and in fact, some of the exams actually include a written portion in Spanish before you can even qualify to take the oral portion, right? So you have to know how to put your acentos if you're going to serve patients in the hospital. Why do you have to know where the acentos go? You know, why is that a criterion for serving patients? Maria Luisa?
You know, and I'm thinking about the work that you've done with the importance of the dialect environment, the disconnect between, even when they are trained in Spanish, that Spanish, what you're saying, is probably so standard that the disconnect between what they know and what the patients bring from different countries, from Latin America, the different registers, the different vocabulary, it must be very hard to connect.
Yeah.
Because there's no connection there.
Exactly.
There's no awareness.
Yeah.
There's no validation of the other information that patients are bringing in.
Yeah.
Right?
Yeah. Yeah. Any other comments on the autonomous view and assistance and acceptance?
Without wanting to as teachers at the university, when we first started thinking of teaching medical Spanish, we thought, okay, we're going to teach advanced grammar with medical lexicon. That's all you need. You need to know these specific words, and you've done it.
Yeah.
And there are many, and I think like in one of your articles, you do talk about in those interpreting moments that they might be very fluent in the technical vocabulary, but they cannot have like intimate conversations.
Yeah. So I think that the assistance view, the view of language assistance, is the idea that communication is happening, right? That we are providing a way to stand in and make communication that otherwise wouldn't happen, right? The view of language acceptance, I think, goes beyond communication and refers to identification, to rapport, to empathy, right? Not simple linguistic, lexical communication, meaning transfer, but rather a more broader type of intersubjectivity, right? A more broader type of relationship and rapport occurring between the two people. So that's kind of the difference I see between assistance and acceptance. And I think that this autonomous view of language, disembedding language from its speaker, disembedding it from its identity functions, disembedding it from its social meanings and the social meanings that it conveys, I think then really positions language to be simply a tool for assistance and not, right, the bridge for acceptance. Okay.
I think it's more cultural too. It's
Yeah.
not just social.
Mhm.
Because the language is not just a system, a linguistic
Sure.
system. It's
Sure.
cultural. It's a cultural product.
Yeah.
So you
Yeah.
can, there is some language which is not accepted.
Mm-hmm.
You cannot bring this theme to a person. You cannot ask these type of questions, you know, in this particular context, or you have to play around and in order to ask this question and bringing another vocabulary, another type of questions. So it's just not just the language,
Yeah.
the social, the
Yeah.
identification. It's just like the environment allows you to put a question or another.
Yeah.
You know, if you are telling, particularly, I work a lot with sexual and maternity health problems. So asking these type of questions are very sensitive.
Yeah.
So you have to know the culture in order to know from which point of, you know, viewpoint you are starting the conversation.
Yeah. Yeah. And that's where I think that language acceptance is really constructed through those cultural. I would go beyond products, and I would say practices too, right? And really, language is just a resource, right? Language in its many different varieties, shapes, standard, non-standards are all just resources that we use to implement and realize those cultural practices, right? So, you know, some of my work with heritage learners in medical Spanish has looked at, okay, well, how do non-standard forms, right, the forms that, you know, would be marked with an X in red in a Spanish classroom, are actually useful to them in clinical functions, right? So you do say traiba and aiga and, you know, and el bile and those kinds of things. That's what you use to create this construction. So really what, you know, this acceptance and identification with patients. So really, you know, to have a medical professional who has at his or her disposal all of the resources of language, right? The different, you know, levels and registers of language is actually more successful at effectuating this cultural practice than, you know, the one who's just trained in academic discourse with lexicon and medical lexicon and advanced grammar, right? Yeah. So the second idea that I pulled from these documents, and it also related to the autonomous view of language and the related desire for language surveillance and control, was a manifestation of a geopolitical view of language that deterritorialized languages other than English, specifically Spanish. By naturalizing the geopolitical belonging of English and the non-belonging of Spanish and other languages, the discourse of health policy effectively neutralizes any contribution of U.S. Spanish speakers to meet language challenges in healthcare. For example, one of the policy documents argues that, and this is up on the screen, bilingual individuals, unless they were trained as health professionals in another country, generally only have skills in the target language, right? So, you know, this idea of conversational skills that are not sufficient, that in order to truly meet the language barrier issue, you need to be trained as a nurse or as a physician somewhere else, right? So why construct languages that are not English as not belonging in the US. We have many native speakers of Spanish in the US, right, who can perfectly well and perfectly provide these services. So I think that the autonomous view of language and this deterritorialization of Spanish really pieced together a portrait of the invention of language in health policy. Now, what I want to do is show you another story. This is Marisol's story. And get you to think about how acceptance, right, this notion of language acceptance is either realized or not realized in the story, and then what could have been done differently to realize language acceptance, to provide this connection between Marisol and the health system. And think about these constructs of language, right? Language as autonomous, language as deterritorialized, as not belonging, and what attaches to language. So when you deterritorialize Spanish and you say Spanish doesn't belong, well, what else doesn't belong with Spanish? So you deterritorialize and you construct Spanish as not belonging, but together with Spanish, you are taking its speakers, you're taking all kinds of other things, right, together with it. So let's watch this narrative, and let me tell you a little bit about the background of these stories that you're going to be listening to throughout the morning. So these are digital illness narratives created by students in a medical Spanish class. The class was called Sociolinguistics and Latino Health. And the final project of the class was for students to identify a family member, a friend, or some individual in the community that had experienced language difficulties in healthcare. I taught this class for probably about 4 years. I taught it every semester. I had in total probably 300 students in that class. And never once, not once, did a student ever come up to me and say, "Profe, I can't find anyone. I don't know anyone who's had a language issue in healthcare." Never once. Every student had a story. Every one of them. Every one of them could immediately identify someone who had experienced language rejection or language tensions and conflict within the health delivery system. So this is one of those stories.
Mi nombre es Marisol Longoria. Soy divorciada y tengo 3 hijos a los cuales he mantenido yo sola. Gracias a Dios ya encontré a alguien que me hace feliz. Desde pequeña fui muy atlética. Siempre estuve en deportes en la escuela, en baile e incluso también fui porrista. Durante el transcurso de los años aún seguí haciendo ejercicio diariamente. Todo cambió el día que sufrí un terrible accidente. Caminando por una tienda, tropecé porque aparentemente acababan de trapear y el piso estaba mojado. Caí de espalda y también sufrí un fuerte golpe en la cabeza. Se me era imposible levantarme. Mi hija, asustada de que tuviera daño cerebral, me llevó al hospital. Yo estaba en un dolor insoportable y estaba completamente doblada en 2 e increíblemente hinchada. Al llegar al hospital y ver que no tenía seguro y que además tenía un acento al hablar el inglés, me hicieron esperar más de 6 horas antes de que me viera un médico. En cuanto me vio el doctor, puso una cara de susto y me mandó a que me tomaran radiografías. Después de verlas, no me dijo exactamente qué era lo que sucedía. Simplemente me dijo que la cirugía costaba más de $100,000 y que yo no tenía seguro ni dinero para pagarlo. Yo seguía muy mala y decidí ir a ver a mi médico en Reynosa. Al ver mis estudios, el doctor me dijo que me había roto una vértebra, que por algún milagro no había tocado mi espina dorsal y estaba asombrado de que me hubieran dejado ir del hospital en esas condiciones. Me dijo que la mayoría de la gente en mi condición queda paralítica al instante y no tenía idea de cómo yo seguía caminando. Me dijo que tuviera demasiado cuidado, que porque con cualquier movimiento brusco yo podía quedar paralítica. Para ese entonces yo ya había entrado en pánico. Regresé con el doctor americano y le llevé mis estudios de México. Incluso después de todo eso, como quiera, se rehusó a operarme y me mandó a una clínica que según él daba ayuda a gente sin seguro en Corpus Christi. Le dije que el dolor era insoportable y ya no podía esperar más, casi suplicándole que me atendiera. Me mandó a hacer una faja para la espalda y me dio grandes cantidades de morfina y relajantes musculares muy fuertes. Gracias a Dios, hoy casi un año después ya estoy mucho mejor. No necesité cirugía y voy mejorando con el paso del tiempo. Los doctores dicen que fue porque nunca perdí la fe ni las ganas de vivir y seguí ejercitándome. La verdad, esta experiencia no se la deseo a nadie. El sufrimiento y sentimiento de rechazo al no saber ni siquiera exactamente qué pasaba con mi cuerpo fue lo peor de todo. Y aunque los medicamentos que me recetaron me ayudaron a dormir y me disminuyeron casi todo el dolor, me seguían llenando la receta con tal de no lidiar conmigo y no me explicaron cuándo ni hasta cuándo tomarlas. Solo me dijeron que cuando sintiera dolor. Desafortunadamente me volví adicta a ellas y batallé mucho para dejarlas de usar. Sufrí de cantidades de síndromes de abstinencia hasta que por fin logré dejarlas. Aún lloro cada vez que me acuerdo y no dejo de pensar que mi dolor y tiempo de recuperación hubiera sido mucho menos si los doctores me hubiesen tratado con más compasión o si hubiese sido un doctor mexicano que hablara español.
Okay, entonces, there you have Marisol's story. How is the narrator's perception of language tied to the outcome of this experience, right? How does she interpret her language barrier as connected to negative aspects of this experience? So you'll see, all of the common complaints about the healthcare system are in this story, right? Wait times, financial barriers, over medication, right? Addiction, right? All of the components, right? And complaints about the healthcare system are present there, and that could lead some people to say, "Oh, well, language is not even a problem, right? It's other things. Let's address the financial issue. Let's address the wait times. Let's address medication and pharmaceuticals, right? Language isn't even important." However, if you look at that, everything, all of these issues are viewed through the lens of language, right? I spoke English with an accent, and I waited 6 hours. Right? So notice how they're both connected, right? And they're linked together. So what would have made that? And then notice also the shift to. So where does correct diagnosis happen? Right? You have to cross a geopolitical boundary for that to happen, right? And then she goes to Reynosa, to Mexico, finds out the cause, and then goes back to get the surgery. She cannot be treated. Yeah. I don't know if they didn't have the surgery was not available, or it could be that in order to get that level of treatment within the Mexican system, you have to be within ISSSTE or the Seguro Social or something, right? And the only way to get into that is to be employed in Mexico, right? So if you're employed in the U.S., then you can't be part of the EAMS or the ESTID, right? So, I mean, that could possibly be a reason. But it's interesting that medical knowledge is obtained, right? I mean, the circuit of knowledge is going past the geopolitical boundary and then bringing it back.
And the doctor couldn't speak with her in the U.S. Like he
Mhm.
looked at the X-rays and said nothing, or
Yeah,
give
yeah.
instructions.
There was no instruction. There was no, instead of saying, this is the problem, this is the diagnosis, the report is, or the patient's perception is, he told me, it's $100,000 and you don't have it, so figure it out, right? Okay, and that is linked then to the language issue, right? So what could have been done to promote greater language acceptance? Would an interpreter have changed it? I don't know if we have some interpreters here. Yeah? Okay.
It's the only way I can think of, because if there's no, even if they have people who speak Spanish there, maybe some medical assistants, sometimes they don't have the knowledge, so they don't know, they can help, but the best way is to have a medical interpreter.
Mm-hmm.
But as you said, not all places can afford that. Okay?
Yeah, yeah.
Big hospitals, they can, face-to-face or over the phone.
Mm-hmm.
They always know how to find help in these
Mm-hmm.
cases, but I don't know which kind of hospital or
Mm-hmm.
is there.
Yeah, it was a hospital on the border region, so most of its clients were Spanish speakers. One thing that's interesting here is that the narrator is not attributing the tension and conflict with the system as just not understanding the message, right? It's the conflict and tension arises from understanding the message and understanding more than the message, right? The social meaning behind that message. So this idea of the accent, right? And I spoke English with an accent, and that indexed me as unable to pay, right? So, and that led to greater wait time, 6 hours waiting in the emergency room. That led to over medication. That led to being sent to indigent care in Corpus Christi. That led to, all of the issues within.
And in this regard, with that antagonistic relationship with the
Mm-hmm.
doctor,
Mm-hmm.
the interpreter would make not much of a difference, I think.
Mm-hmm.
The interpreter would be in the middle of this
Yeah.
antagonistic relationship.
I think
Yeah.
the doctor didn't care, and he wanted to spend a minute more than what he had to.
Yep.
She had no money to pay.
Yeah.
She had an accent, and
Mhm.
he didn't care.
Yeah.
If he would have cared, he would have probably found someone, a nurse, someone that could come in for 2 minutes
Mm-hmm.
and explain. He didn't want to waste money. I mean, time. Because
Time is money. Yeah, you're right.
Another thing that I see is that, Spanish patients, but they're super Chinese patients, they don't complain because they don't know how to complain. And
Yeah.
so also they can
Yeah.
take advantage. If you have someone American, they can complain, I've been waiting here for 1-2 hours, and they can express the Spanish is going to be there sitting in a corner 6 hours waiting without saying anything.
Mhm.
And they
Mhm.
know, so we're not.
Yeah.
He can wait more than the others, so
Mhm.
he can stay here.
Yeah.
Yes, I mean, it is clear that the doctor was not really
Mhm.
up to help her
Mhm.
because she's saying that he was concerned when he saw the results, right?
Mhm.
But I'm also, I don't know this, I'm asking if the third party, the interpreter, also puts pressure on the doctor's side to be more accountable for what he's doing, and not having that third party there allows sometimes doctors to be able to do exactly this. I mean, can a doctor have done that with a third party there?
I-
What
I-
kind of the
yeah.
third party, what those
Yeah.
alliances are?
Yeah.
I don't know, but I think it's also.
Yeah. So if you look at some of the research on interpreters, what you'll find is the alliance is in fact with the provider, right? So they're used as gatekeepers, they're used as co-diagnosticians, right? Interpreters fill these other institutional functions and not, you know, the whole notion of patient advocacy is really, you know, within certification and training and those kinds of things. It's really not encouraged. I mean, it is encouraged, but the parameters to advocate for patients are very, very limited. Right?
I don't know if it would have made any difference if the hospital and the physician, the doctor would know that this has happened in a commercial establishment where there'll probably be an insurance.
Yeah,
so
yeah,
they'll probably
yeah.
get $100,000.
Yeah.
So,
yeah,
so
yeah,
I mean,
yeah.
so.
Yeah. I think that there is certainly much more than language going on here. However, it's interesting to see how through the lens of language you can pull all these things together. It's kind of like language seeps into all these crevices, right? Financial and insurance and legal and, you know, all of these different crevices that language kind of holds them together. And the way that the patient is interpreting that experience through language, right, is interesting. Yeah.
Well, to make a difference, they got there to the hospital, she failed.
Mm-hmm.
Yeah, she failed
At Walmart.
At Walmart.
Yeah. Yeah. Well, there's no shortage of ambulance chasers in the Rio Grande Valley. So. Okay. So let's go on to the next area of research, and then we'll take a break after this session. Like at 11:30. A little bit after 11:30, we'll take a little break. Okay, so the second line of questioning in my research on language policy in healthcare then deals with patient perceptions of policy implementation, right? So how do patients view this policy, right? How do they interpret it? So on the one hand, I've explored ways in which local interaction patterns shape the clinical encounters experienced by Spanish speakers in the health delivery system. And on the other hand, I've considered the implicit messages that are conveyed through the use of Spanish language on signs and written materials in healthcare facilities. So two aspects. And we'll just look at the first aspect now, the local interaction pattern. So turning first to this analysis of local interaction patterns, I argue that policy implementation always occurs within local practices of communication and interaction. So local practices, I argue, can override and reduce the very communicative efficiency that policies are meant to produce. Local interaction patterns I view as these durable and pervasive ways of interacting that reflect and sustain the local linguistic order. And the idea of a local linguistic order, I follow Boni Urcioli in defining it as the bounded spheres of relations that license and legitimate language use in a bilingual environment. So I found two specific local interaction patterns that appeared to shape patient perceptions of the encounter. The first is what I called the performative elevation of English. And by the way, if you look at these slides here, they have the references to the articles that I'm talking about. So there's one and the other. Okay. And we can make the slides available. Right, Paco? We can make the slides available to them? Yeah, okay. Okay. So the first was what I call the performative elevation of English. And here I'm referring specifically to a pattern of language choice when initiating a conversation. So anyone who is bilingual, right? Many of us are bilingual, and every time we open our mouth, Every time. We have to make a choice, right? Am I going to speak English or am I going to speak Spanish? How do you make that choice? How do you decide? What determines it? It could be environment, where you are. It could be what you're talking about. It could be who you're talking to, right? I mean, those are all factors in deciding language choice. What if it's not clear? What if the place where you are, you speak either English or Spanish? What you're talking about, you say it either in English or in Spanish, and the person you don't really know. So what's your default? Huh? English, right, as the default. And this is what I'm talking about in terms of the performative elevation of English. The choice of English as a default is itself a performative, right? So in this study, I looked at this and this one default language choice, and I found that the absence of these cues and the default interaction pattern in English was talked about by the patients that I interviewed. So the first example on the screen illustrates the interaction patterns right there. De hecho, yo cuando voy me pongo en la ventanilla como siempre y me hablan en inglés. Yo les digo, discúlpame, pero no sé inglés. Right? So every time I go up to the window, right? Como siempre, as always. Every time I go up, may I help you? Right? And then the reply, discúlpame, pero no sé inglés. I view this interaction pattern then as a performative that constructs English as the natural, normal, and default medium of communication. At the same time, as a performative, I think it also reduces Spanish to a non-natural, abnormal medium of communication, right? So notice that within that interaction, there's always that need to say, discúlpame, I'm sorry, but I don't speak English, right? And you have to state that each and every time the interaction happens. So notice the durability, como siempre. The subordinated position, me lo puede decir en español, the subjugated and subordinated position that emerges of having to state every time, I don't speak English, I don't speak English, I don't speak English, right? And what is the impact of that as a performative, right? So the next example on the screen illustrates how this pattern results not only in a subordinated positioning of the Spanish speaker, but also in lack of health information, right? So health information is kind of cut off because of this same performative. So we asked a patient, cuando usted va a comprar las medicinas, ¿usted pide las instrucciones en español? And the response, sí, se las pedía en español, pero me las daban en inglés. So I asked in Spanish and I got them in English, right? So the health information is cut off as well. The second interaction pattern that I found is what I called the delitericization of Spanish. And this is an interaction pattern in which literate language is assumed to be in English. Literate language is assumed to be in English. What's written is written in English, right? Written language is in English. And this is in the same way that English is performatively privileged as the default language in communication, in oral communication, it's also privileged as the dominant language of print environments. So healthcare providers would routinely refrain from providing any written materials, even in cases where this is the standard of care, like in post-operative discharge. Person is discharged after an operation and they're given this stack of papers, right? So the standard of care is to provide written information. However, even in these cases, they would either provide the materials in English without anything and just give them, right? Or provide an accompanying oral explanation. So these two options are illustrated in examples on the screen. And these are both cases of post-op discharge. ¿Y no le dio algún escrito, panfleto? No, no me dio nada, nomás fue lo que me dijo ya. Right? So I received nothing after the discharge. ¿Y no pediste tú que te diera la información en español para lo de la rodilla? Se lo pedí, pero no lo tenían, y por eso te la explicaba él en español, porque no lo tenían en español. Right? So it's this switching to the oral medium, right? When written channels are required, and I call this kind of a deliterarization, right? So the proper place of Spanish is not written, but rather oral, right? Now, this deliterarization, I think, provides a fractured and non-reinforced transmission of health information that really places significant a priori constraints on the patient's ability to comply with physician indications, right? So we expect the good patient, right, to leave the hospital and follow instructions, right, and come back 3 weeks later and we'll see the results. But compliance in this environment is not the same, right? You weren't given the indications, right? And this, I think, harkens back to Paul Farmer's analysis of compliance as a behavior that is co-constructed between providers and patients. You know, there's a tendency to say, oh, well, these patients never comply, right? You give them a prescription and they don't even fill it, right? And there's, you know, it's constructed as something that the patient does. The patient can either comply or not. And Paul Farmer argues, well, it's really co-constructed. It's the patient, the physician and the provider has as much responsibility in compliance as does the patient, okay? So let's watch another story. This is Michelle's story. And in this story, I want you to think about this notion of compliance, right? This notion of being able to follow directions and follow health provider recommendations and the role of language therein. So this is Michelle's story.
Mi nombre es Mari Carmen González. Tengo 3 hijos, 2 niñas y un niño. Michelle, mi bebé, tiene 12 años de edad. Siempre ha sido una niña muy bonita. Desde chiquita, Michelle ha sido un poco extraña, pero a la edad de 7 años las cosas empeoraron. Desde entonces ha sido diagnosticada con esquizofrenia, autismo severo, retraso mental y epilepsia. Estos pasados años han sido muy difíciles. Soy madre soltera y es difícil mantener un trabajo fijo con todas las visitas al doctor que mi hija tiene. Fui a una escuela de cosmetología y tengo mi propio negocio en casa. No gano mucho, pero me permite atender a mi hija. Recuerdo la primera alucinación que Michelle tuvo. Ya era noche y ella empezó a gritar que tenía insectos encima de ella. Se empezó a quitar toda la ropa y después todavía se tallaba todo el cuerpo llorando que tenía insectos. Pero no había nada. Ahora toma medicamento para controlar las alucinaciones. Michelle pasa la mayoría del tiempo que está en la casa en el pasillo y platicando con ella misma. Es muy difícil hacer conversación con ella. Quisiera poder ayudarla más, pero es difícil tratar con ese sistema en los Estados Unidos. Hablo muy poco inglés. Es difícil comunicarme con las maestras de mi hija. Tenemos juntas para discutir las necesidades educativas de Michelle. Me dan su palabra de que van a hacer lo posible para ayudarla. Nunca cumplen sus promesas. Siento que me ignoran la mayoría del tiempo. La escuela es solamente una guardería infantil. Mi hija tiene 12 años de edad y no sabe leer. No puede sumar ni restar. Casi no hace oraciones completas. Es frustrante ver a mi hija en la situación que está y no tener una voz en este sistema para ayudarla. Me siento igual de impotente con los doctores. Las enfermeras y secretarias son muy groseras. Parece que están frustradas porque no sé inglés y a veces se enojan porque llego un poco tarde a las citas. pero muchas de las veces tengo citas con varios doctores el mismo día, y si un doctor atiende a Michelle tarde, llego con el otro doctor tarde. A veces es un poco difícil adherir con las órdenes de los doctores. Por ejemplo, la neuróloga de mi hija ordenó que Michelle tuviera ayuda de 1 a 1 en su escuela. Tuve que pelear con la escuela para que accedieran a darle ayuda de 1 a 1. Hasta ahorita no lo han hecho. Las personas de la farmacia han sido de mucha ayuda. Michelle toma 6 diferentes medicamentos todos los días. Los frascos con diferentes colores simplifican mucho las cosas. Cada día es una batalla constante para proveerle a mi hija ayuda. Creo que si supiera inglés, los doctores y las maestras me tomaran más en serio. Estoy yendo a la escuela para aprender inglés y ojalá podré ayudar a mi hija más cuando sepa inglés. During the class, we talked about compliance to doctor's orders. I'll be honest, I used to always blame the patient for not adhering to doctor's orders. But is it always the patient's fault? I see how hard my mother tries to adhere to the doctor's orders in order to help my sister. But as is often the case with non-English speakers, she is unable to receive the respect necessary to carry the orders out. Although many doctors subscribe to the blame the patient mentality, for some non-English speakers, it seems like some orders are just out of reach.
Okay. So how does that story illustrate the role of language and its connection to this issue of compliance? I mean, she summed it up really well at the end, right? I mean, she's actually a physician. Actually, this person is she just finished medical school, and now she's doing a residency in El Paso. So, but how does she sum up that? What are the barriers that the mom is facing?
Which she's not facing.
Yeah, yeah.
Yeah, she pointed out that the physicians or when they receive the instructions, they are frustrated because they don't speak English.
Mm-hmm.
And I've seen that frustration in a workplace. They assume that they don't speak English and that they don't like it, and they don't make the effort to try to make it easier for them. So that really annoys them, that they don't speak English. That's the barrier.
Yeah. These assumptions, right?
Yeah.
That, you know, if you don't speak English, you must be lazy. Because my granddad came here from Italy, and you know, but you know, to what extent can we say that this, you know, looking at the whole narrative, where's the laziness there? What's lazy? What's lazy about, you know, going to beauty school, putting a business in your house, going to class and trying to learn English? Because, you know, there's nothing lazy in that story anywhere, right? Yeah. But yet the assumption is still there and constructed in that interaction, right? What else did you see in the story?
I come to be saying the issue of class. And I imagine the rich Mexicans who travel from Mexico City to Houston to be treated. Maybe they're not bilingual, and they're probably treated very well.
Yeah, and they not only come from Mexico, but they come from Saudi Arabia and from United Arab Emirates, and you know there's a huge push in hospitals to create these destination medicine, international patient kinds of services, and they often link to the interpreter services. So at Ohio State, the same person who is the manager of interpretive services is also the director of destination medicine, right? Destination medicine, se llama. Yeah. And it's mostly in our cancer center which has excellent cancer care, and they get patients from all over the world. But yeah, the availability of interpreters, right? The treatment, these are cash-paying customers, so they roll out the red carpet, right, for them. I had a student who did a study in Houston, comparing the international patient language services in, I think, Methodist Hospital, and the interpreter services in Ben Taub, which is like the public hospital. Totally different requirements for the interpreters, totally different, workforce, and ability coverage, right? Day and night, right? And yeah, so when there's money involved and when you can charge for it, then, then it's there. And when you can't, then it's cut out. So yeah, class certainly is huge.
I know that, resources. I'm thinking I grew up in a family of doctors, so I heard a lot of similar stories back in Mexico City, and I wonder if all these issues are also magnified by, that the hospitals also struggle so much in terms of the resources. I know that it's more than that, but I'm just thinking about how much that the whole system, it's so ill-designed to really provide some of the people with the most need.
Yeah.
With more resources. You could go to Mexico City and hear stories of these same mothers. The issue of language is not there, but the issue of class is there. And the disconnection between parents and teachers, parents and doctors, more or less the same. I was thinking about that. My mother worked many times. She's a family therapist, and she worked with for many years in a hospital, helping families with children with kidney issues to connect with the doctors, and it was impossible. So there's so many disconnections even without the language, and there's this lack of understanding of who the patient is that is sometimes missing in the training, the medical. And when they have it, the system is so demanding that they cannot really perform in that way. So it's a very intricate and complex, and certainly in this context, language and culture, it's just at the center of it.
No, what I found in my in my thinking and my research on language and healthcare, I don't think that if we suddenly created a system in which every non-English speaker received all of the care that they in their own language, that it would solve all the problems. It wouldn't. But I think that language magnifies and shapes the problems that already exist in very different ways, right? In very unique ways.
And the class issues here are lazy, but they are ignorant. And they can wait. So even we have wonderful centers, of course.
Let's continue. So I'm going to talk about another study that looks at patient perceptions of policy implementation. So going back, the language access mandate. So in this study, I'm really focusing on the fourth access mandate about signage and written materials, and how what we call in sociolinguistics, we have the term linguistic landscape to talk about these visual manifestations of language, and that's kind of where this study is coming from. So in this study, what I wanted to do was to uncover reactions to signs and written materials that appeared in Spanish in healthcare facilities. And to do this, I recruited young bilinguals between the ages of 17 and 20 who regularly accompanied their parents or grandparents to doctors' offices and clinics. And I used a particular methodology for this study called photo voice. And photo voice is a methodology very common in public health and in health assessment kind of research. So basically what it is you define a group of participants, you provide them with a camera, and you ask them to go out to whatever space is under study, and you ask them to take pictures of things. And they go around, and they, if you're doing a health assessment, they might take pictures of mold in a stairwell. They might take pictures of garbage on the street. They might take pictures of all these different things. And once they collect the photos, they come back together and discuss critically why they took this photo, right? So why did you take this photo? What does it mean? What can we do? And that's kind of the photo voice methodology. So I try to apply this methodology with these young people and ask them, okay, go to the places where you normally accompany your parent or your grandparent to receive care, and take pictures of any language that you see, on signs, on pamphlets, in the waiting area, and in different places within the healthcare facility. And after that, we got back together and we reflected on the meaning of these pictures. So the youngsters in the studies amassed a total of about 150 photos, right? They took 150 photos, and then they met in small groups afterwards to discuss their reactions to the photos. And what they reported, I think, was generally a disbelief at this lack of materials available in Spanish. So, they had never paid attention to it before, but when I asked them to go take pictures, well, where's the Spanish sign? There's one in English, but where's the Spanish one? And that was kind of a disbelief, an eye-opener for them, that there was such little availability in Spanish compared to English. What they also pointed out was that most signs in Spanish tended to be about making payment and about hospital and clinic rules, right? So don't leave your children unattended. That would appear in Spanish. Or payment due at the time of service. That would be in Spanish, right? But, signs about, or in posters about prevention, about healthy living, about how to understand a disease, those appeared in English, right? And they kind of questioned, well, why? So youngsters also discussed the character of Spanish signs. And within those signs, they observed a preponderance of spelling errors, translations, that were incomprehensible. And they really pointed this out. They focused in on that. And this is a picture that one of the participants took. So you can see it there. Patients, if you need to urinate, this is a urology clinic. Okay, so if you need to urinate, please ask for a specimen cup. And then in Spanish, si tiene que orinar, favor de pedir una copa para un análisis. And this is what one of the students, so we asked the students to take the pictures, to write a caption, and then to come back. So this is the student's caption for that picture. And he says, in a urology clinic, these signs give instructions for making appointments and providing a urine sample. This is the worst translation I've ever seen. It's difficult to understand what the Spanish sign means. These kinds of signs show that there's very little interest in Spanish-speaking patients and that there's a lack of professionalism in the clinic. And this was a theme that recurred over and over again, that these constructions of these manifestations of Spanish on the linguistic landscape really created a message and conveyed a message about Spanish speakers and their importance, or that they're not important, right? That they're, we put a sign in Spanish just to put it, right? So we would never write a sign like that in English and put it up, right? That made no sense, right? But why do we do it in Spanish? And that's kind of the line of questioning that they're beginning to ask. And I think it's interesting to see how this idea of standards and non-standards plays out in very different ways within the healthcare environment. You know, so we talked about the impact of imposing linguistic standards and how that cuts patients out from communication and excludes people who should be included in providing language access. But then you see this other side, right, where standards also communicate something, right? They communicate a meaning. So it's a complex area, I think, and the received notions, you know, our traditional notions of standard, non-standard, I think really need to be reanalyzed and questioned within this environment. Luis?
And this is in the valley.
This is in the valley.
Full of Mexicans who you could pick up someone in the street.
Yeah.
That's Google.
Yeah, probably Google. Yeah.
But I think it's 90% Mexican in that region.
Mm-hmm.
It's easier to type it in Google than ask someone.
Yeah. You know, there's, I think really the conclusion was that the manifestation of Spanish on signs in the clinic revealed this underlying lack of interest in Spanish-speaking patients. And there's kind of a disconnect, right? Why is the language on the landscape, right? The language that I'm seeing and the language that I'm hearing are completely different. I walk into this place and all I hear is Spanish. But then I look around and it's nowhere to be found, right? Or it's found in these particular shapes. So, you know, I think one of the participants stated it forcefully, and he said at the end, you know, I think that hospitals need to give this more attention so that they can help people, because sometimes all the hospitals see is money, but it's more than that. It's life, it's health, and well-being for everyone, right? And this was kind of one of the conclusions that came out of that that project. So I want to show you now a video that was made kind of summarizing the project. So this is just a video that summarizes the project, and we really we created it to provide it to the healthcare providers, right? To provide it to hospital administrators. We'll put it up on YouTube. I don't know that it got a lot of hits from from doctors' offices, but here it is.
Y hay una traducción exacta, medio exacta, confunden al paciente hispanohablante.
por el área donde vivimos, lógicamente, sí, mucha gente acude a México, diversas razones, ¿no? Una de las razones podría ser es el costo de ir a México, que es muy distinto el de aquí a México. Y otra de las razones también muy importantes es que sienten la confianza de que van a estar atendidos por alguien que realmente les está atendiendo en su idioma.
sabe el inglés, no va a saber cómo combatir y va a estar, si llega a tener la bacteria, va a estar pasando, entonces no va a saber cómo combatir, puede ser una epidemia.
So, you know, this kind of sums up the entirety of the project, and you can see the reactions towards the end of what the way that they're interpreting this this presence of Spanish on the landscape. So, the two studies that I talked about, the local interaction patterns, and then this one on the photo voice or linguistic landscape study, I think highlight the ways in which language and healthcare policy is really shaped by local practices, right? I mean, it's shaped by the practices in which it's enacted, and oftentimes this can enlarge rather than bridge the gap between Spanish speakers and the health delivery system, right? So these practices in which policy is expressed and implemented can really create a greater gap than what what the policy is intended to close. So let's go to the third line of research, and that's the impact of language policy on Latino health professionals. So this is the third line of questioning in my research on language and healthcare policy, looking specifically at how language policy in healthcare impacts Latino health professionals, right? So how are Latino health professionals impacted in this with the implementation of this policy? So one study looks at how organizations deploy bilingual personnel to meet the needs of Spanish-speaking patients, and another more recent one looks at the impact of language surveillance and control on bilingual nurses' use of Spanish in the workplace. So we'll look at those two separately, and then we'll consider another story, and finally we'll talk about training, education, and the role of Spanish educators and Spanish language scholars in language and healthcare. So the first study was a 2006 study that I conducted. It was a survey of clinics and doctors' offices in the lower Rio Grande Valley to determine the extent of and availability of bilingual personnel. The study demonstrated a hierarchical distribution of bilingual health professionals in the healthcare facilities surveyed. So the greater the level of specialization and the greater the pay rate, the less bilinguals were available. So if you look at the health workforce as kind of a pyramid with highly specialized physicians at the top, and then highly specialized and more, family practice or internal medicine. And then you have nurses who are also divided among specialized and more vocational. And then you have medical assistants and clerical staff at the lower end of the pyramid. So the greater the level of specialization, the greater the pay, all the way up the pyramid, right? The less availability of bilinguals. The lower the specialization and the lower the pay, the more bilinguals we found, right? So the medical assistants, clerical staff tended to be bilingual. There were more vocational bilingual nurses than there were RN bilingual nurses, right? And physicians, an oncologist or an endocrinologist that was Spanish speaking was much less common than a family practice physician or an internal medicine physician and so forth. So that was kind of the distribution that we found. So there was less representation of bilinguals in the physician category than in the nurses category. By far, the largest contingent of bilingual personnel was to be found among the medical assisting and clerical personnel. And the survey revealed that it was precisely at this level where the personnel shouldered the greatest burden for language assistance, right? So, yeah, we don't have that problem in this clinic because our medical assistants are all bilingual and they do the interpreting or the language access. So really what this study found was that the implementation of language policy in the lower Rio Grande Valley was really largely shouldered by the least educated and the least well-paid segment of the healthcare workforce, right? So in this study, I really wanted to point out how bilinguality and language becomes this exploitable part of being a healthcare professional, specifically in the Valley, and how it's kind of connected to medical assisting and clerical staff and those less paid areas of the healthcare workforce. The next study is a more recent one, and here, remember I talked about the Joint Commission the Joint Commission accreditation standards, and how that is really creating a more tense and cautious regulatory environment for hospitals. They're beginning to step up and try to comply with language access mandates. And what we looked at was a particular hospital in Phoenix that is trying to maintain and comply with language access mandates for accreditation purposes, and they've implemented a policy of compulsory language testing, right, for all nurses, all personnel who work directly with patients in Spanish. So we looked particularly at nurses, and we wanted to understand the effect of this compulsory testing on Latina nurses, right? How did it affect them and their use of Spanish? It's important to note what that test was. So the test is actually a service. It's outsourced to the same company that provides telephone interpreting to the hospital, right? So Siricom is the company, and the company provides telephonic interpreting and provides testing to the hospital. So the test actually had two parts. It began with a written portion in which nurses were to demonstrate their knowledge of written Spanish, their ability to read and understand text, their ability to write, with standard orthography, to use accents in appropriate places, and so forth. Once they passed that test, then they could move on to an oral test that looked at medical terminology and ability to translate between English and Spanish. What we were interested in finding is how this policy of compulsory language testing unevenly affected Latina nurses. And what we found was that many of the Latina nurses that we talked to characterized the test as hard, right? Well, yeah, have you taken the test? No, that test is too hard. It means I would have to study, I'd have to find time to kind of refresh my memory, and I haven't written Spanish in ages, so and that was the approach to the testing. Some who did take the test indicated that they had failed it. So what our interviews attempted to do was to try to determine how the policy limited the use of Spanish on the job by the nurses. And while the nurses indicated that they had not passed the test, they also stated that they were still compelled to provide services to Spanish-speaking patients. And this not explicitly by the hospital. The hospital was telling them, no, you're not credentialed to speak Spanish, you cannot speak Spanish, and if you do, you could be sanctioned and you could lose your license as a nurse. But yet on the floor and in practice, they were being called in by physicians, and a doctor has a Spanish-speaking patient, or a resident doesn't speak Spanish. Hey, there's the nurse. Can you come and help me out? So there was this expectation that they would provide the service, right? And at the same time, a institutional mandate that sanctioned them for providing that service. So they were kind of caught in the middle. It was a conundrum for them. So we also found that not only was the policy creating this sanctioning for using Spanish at the same time that physician behaviors were exactly the same, and they were continuing to have this expectation of calling on Latina nurses to provide the training. We also found that to provide the language services. We also found that the language testing protocol actually superseded any previous training or accreditation, right? So one of the nurses interviewed had graduated from a well-known bilingual nursing program at a local community college, right? She graduated as a bilingual nurse from one of the local community colleges, but even so, she was not permitted to freely interact with patients in Spanish. So she had to pass the test, right? And if she didn't pass the test, she couldn't speak to them. So in this study, we found that this tightening regulatory environment and the development of a stricter testing regime actually resulted in less availability of language access in the hospital, right? And it put the Latina nurses in this very difficult position, right? Where, you know, on the one hand, you had these expectations that, you know, you're working in the hospital, you're on a care team, you're assisting and providing the support to the team that you're supposed to, right? And then on the other hand, you had hospital policies saying you're not credentialed and permitted to speak Spanish. So, and that's really what we're seeing with this tightening regulatory environment, and these language access measures actually being enforced. You're seeing that, you know, rather than having a situation in which we assess what our linguistic capabilities are and what our assets are, and then go from there and say, okay, these are my assets. How do we deploy them in ways that are productive and beneficial and add quality to the care? We simply take we impose these generic regulations, and what happens is we wind up punishing Latino nurses for the Spanish that they do speak, and actually creating an environment in which Spanish is avoided and less used by providers. So that's the more recent type of research that I'm working on, and we have a paper that's I did this with Carmen King de Ramirez, who's at the University of Arizona, and we have a paper that's forthcoming on that. So that's this paper here, From Valuable to Vulnerable. Okay, so those are the two studies on providers and healthcare. So any comments on those?
Do the tests cost?
They cost the hospital. They cost the hospital, not the nurse, no.
And they are never tested in their English grammatical skills?
No. Yeah, so, yeah.
Is Spanish in this case of this bilingual nurse is recognized as an added skill that they get compensated
There's no
for,
compensation, no.
I mean, you could be cleaning lady, but if you speak Spanish, we are going to assume you are prepared to interpret.
So that's what the compulsory testing is trying to control, right? So the compulsory testing is trying to say, okay, we need to figure out a way to ensure that everyone who's interacting with Spanish-speaking patients is capable of doing so, right?
They're going to get compensated if they are.
There's no extra compensation for it. No bonus.
No real motivation.
No nothing. Yeah. And remember that I think the in the language access mandates that I talked about, you know, that inclusion of at no cost was really, you know, created a situation in which the policy couldn't really be effective, right? I mean, either Congress would need to make this an act and appropriate funding for it, or, you know, it would have to be, you know, there have to be some mechanism to fund language access, right? And the absence of that mechanism has really led to significant lack of progress, I think. And yeah.
About the test, who is the standard, who provides that?
So the test in this particular hospital, it was provided by the same company that provided the telephonic interpreting services. So there are maybe 3 or 4 major telephonic interpreting companies, right? So you have Syracom, you have Language Line, you have Lionbridge Technologies, and they really are organizations that cover insurance, social services, hospitals, schools, they cover anything, right? And a telephonic interpreter, 1 minute will be interpreting for a nephrologist, another minute will be interpreting for a counselor. So they really just span the whole spectrum of any potential interactions, right? And so the same company that provided the telephonic services is the company that developed and provided the test, right? The test was a written grammar orthography test as sort of a screener. And the question that they're trying to answer with that test is, are you proficient in Spanish? And the definition of proficiency is not the definition that clearly is used worldwide to talk about proficiency. We talk about ACTFL, or we use the Common European Framework, or something that measures function and ability to utilize the language in different contexts. But instead of using that, they had this written test, which is grammar and orthography. So once you establish proficiency, then you can move on to testing interpreter abilities, right? So the oral test was more, they would give you scenarios, they'd give you a sentence, and you translate it from English to Spanish, from Spanish to English, and they would check the accuracy, or the precision. Yeah. So very similar to the national certification exams for interpreters in terms of the interpreting test. Now, the national certification doesn't have any prescribed way of showing proficiency. You can do it with an ACTFL OPI score, you can do it with a DELE score, you can do it with coursework or credits in Spanish. So there are different ways of showing it in terms of the national certification for interpreters. But this particular hospital was doing it that way. So, if it were national certification, this one nurse who had a degree, her nursing degree was in bilingual nursing, she would have shown her proficiency and been able to take the oral test, which would be more appropriate, I think, for her, right? In terms of, having to go back and study, what the rules of accents are, and it's kind of ridiculous to ask the nurses to do that. So, yeah.
Difference with someone that's first language is Spanish and that's interpreting into English, or someone that first language is English and is going to be interpreting into Spanish.
They talk about A language and B language, and you should translate into your A language or interpret into your A language. I think it becomes really complicated when we think about Latinos in the U.S., right? And what is my A language? I don't know. What's my B language? Depends when, right? Depends what I'm talking about, right? So I don't know that that's been that really in highly bilingual context that is really applicable. I think it's more specialized and where the A and B language are truly first and second, right? Which may not be the case for much of the Latino population. I think that there are ways that we can more effectively utilize and leverage the language abilities that exist in the clinic, right, and in the workforce, right, and take that and use that to wisely develop a language access and language acceptance strategy, right, for Latino patients and Spanish-speaking patients. So let's look at another story, and this will be the last one. This is Arturo Emanuel's story. And I want you to think about the implications for training health professionals, right, through this story. So what are the implications for training health professionals? And then we'll talk a little bit about that.
Durante 9 meses, Gisela se ilusionó profundamente con el pequeño bebé que estaba procreando en su vientre. Todo marchaba a la perfección. Sin embargo, en su última cita con el ginecólogo, le avisaron que se le iba a tener que hacer una cesárea de emergencia debido a que su bebé se le paraba el corazón por
Es que mira, haz de cuenta que su cuerpecito, el oxígeno en su cuerpecito ya no fluía bien. De un 100% llegaba al 66% y lo más que llegó fue un 88%. Y de ahí fue como que empezó todo. Le pusieron sondas, también le pusieron inyecciones, tratamientos en los cuales no tenía idea de lo que era. Después lo tenían todo entubado, lo tenían sedado. Imagínate un niño tan chiquito con un chorro de sedantes. No me dejaban tocarlo, ni me explicaban lo que tenía. Eso era mi angustia, porque, ver a mi niño así y ni siquiera sabía lo que tenía. Y pues nada más de repente llegó una enfermera que medio hablaba español, porque ni siquiera lo hablaba bien. Medio me explicó que mi niño tenía las venas invertidas, las venitas de su corazón, y que lo tenían que trasladar a San Antonio.
Cuando llegó a San Antonio, todo fue diferente. Había cardiólogos que hablaban español y se tomaban el tiempo para explicar cada procedimiento que se le administraba a su bebé.
Ahí en el hospital de McAllen varias veces dejó de respirar y era yo la que le tenía que hablar a las enfermeras para que lo vinieran a atender. De hecho, una de las veces contrajo una infección que fue lo que hizo que leve empeorara, y era porque lo tenían demasiado tiempo entubado.
En San Antonio, al pequeño se le hizo una cirugía de corazón abierto. Cuando aparentemente ya estaba bien, lo regresaron a McAllen ya solo a recuperarse. Mas 5 días después de ser trasladado, de nuevo empezó a decaer por completo y a batallar con la respiración. La doctora le avisó a Gisela que ya no sabían qué hacer y lo regresaron a San Antonio.
Cuando regresamos a San Antonio, los doctores estaban bien sorprendidos porque no se explicaba si ellos lo habían regresado al hospital de McAllen estable, cómo era posible que el niño regresara aún peor que la primera vez. Eso era lo que les sorprendía a ellos.
El doctor le explicó a Gisela que lo que Arturito tenía era que un lado de su diafragma estaba paralizado por la operación del corazón y era el motivo por el cual estaba batallando para respirar. Lo estaba atendiendo un especialista de la garganta, ya que en McAllen se le habían irritado e hinchado los pulmones al entubarlo. Pero durante este tiempo se le empezó a acumular líquido en sus pulmoncitos y el doctor iba a intentar extraerlo con una jeringa.
La enfermera me dijo que me saliera del cuarto de las incubadoras, pero pues yo no me quise salir. Al momento de que le pusieron una jeringa en su pecho, le empezaron a sacar un líquido, empecé a ver cómo mi bebé se desangraba y le empezó a bajar un chorro la presión. Además vi como anunciaron el código azul, de repente pusieron a llegar como 10 enfermeros y 5 doctores. Ya solo veía como le hacían compresiones de pecho y su cuerpecito se ponía morado. Así estuvieron como 40 minutos, pero ya no respondió.
Con aproximadamente un 93% de una población latina hispanohablante, es realmente una lástima que en el Valle haya tanta necesidad de doctores capacitados, no solo en medicina,
sino en lenguaje y cultura, para darle a los familiares y los pacientes un cuidado de calidad. Tal vez fue negligencia médica, tal vez solo fue el plan de Dios, mas la desesperación y amarga angustia que pasaba Gisela al no saber qué tenía su pequeño pudo ser disminuida si tan solo los doctores le hubiesen dicho que estaban haciendo su mayor esfuerzo y no dejándolo con la idea de que su bebé estaba siendo mal atendido.
All right, so those are the stakes, right? I was very interested in the way that she connected the story to training, right? To why can't we ensure that our healthcare workforce is capable not only of treating, but also of communicating, right? And also of providing knowledge and messages to patients, so that they will understand, right? So that they'll at least know that you're trying your best, right? So that's I thought that was a very powerful story and a very moving one. Xochitl actually is now doing a PhD in public health at George Washington in DC. But yeah, so how do we approach this training issue? And let me just share with you some of my thoughts. So I used to think about medical Spanish, and I've kind of moved away from that a bit. I don't like the term medical Spanish. I think we need to think in broader terms. I think that medical Spanish really focuses in on lexicon, right, and advanced grammar, the kinds of things that we were talking about before. And I think we need to broaden it out and think more about, Spanish for the health professions, or Spanish in the health professions, or even Spanish through the health professions, which is kind of the direction I'm moving in these days. So thinking about, okay, how do we distribute language instruction throughout the curriculum? How do we distribute it? So we want to serve our pre-med Spanish majors, right? But what happens when we finish? Do we leave them at the door of medical school and say bye-bye? Or do we also engage productively with medical schools, and engage productively with nursing schools, and engage productively with other professional schools that are training health professionals? And how do we engage, right? What does that instruction look like, right? What are the objectives and goals that are best pursued at the undergraduate level, and what are the objectives and goals in language and language development that we can develop and deploy when students are in more advanced stages and have better clinical knowledge. I think that there's a disconnect in the way that we teach Spanish in the health professions, with dialogues and simulations of patient care and clinical medical interviews with undergraduate students who have no idea how to do a medical interview, right? They have no idea how to do a health assessment. So why are we having them practice doing this in Spanish at that point when they still don't have the clinical skills? So what I'm arguing for is more of a articulation of language skills and clinical knowledge, and how do those things go together across the pipeline. So at UT Pan American, my work was mostly with undergrads, and at Ohio State I've been doing more and more with the College of Nursing, the College of Medicine, and trying to. I think that that's really what shaped my view of this, more holistic approach to teaching Spanish through the health professions, right? So, in the undergraduate, we can deal with more cultural things. We can deal with the big questions that shape, right, the language skills. And then in the professional schools, we really draw on what they're developing in terms of clinical assessment, in terms of conducting a medical interview, in terms of delivering a diagnosis, right? So how do we, once they learn how to do this within the context of their professional training, well, how do they do it in Spanish, right? And deliver the instruction in that way. So that's my thinking moving forward, kind of a pedagogy coming out of this policy research. Just in terms of the policy research itself, in the informe that's available out there, I talk about patient-centered outcomes research and comparative effectiveness research, which is the direction of health services research today. It used to be that we would focus on evidence-based care. So we want to know if we have a intervention, if we have a treatment, what is its evidence base? How effective is it? And at what statistical level is it effective? And today I think there's a new view, which instead of focusing on the efficacy of a particular intervention and defining that intervention as a standard of care, rather we're saying, okay, we have 3 or 4 possible treatments, 3 or 4 possible interventions, and we have a patient with a unique background, unique beliefs, a unique physical condition. What is the best option for that patient? And that's the idea of patient-centered outcomes research and comparative effectiveness research. So taking different comparators and seeing, okay, which one is better when and to what extent, right? And I think that there really is a future in applying this model to the way that we provide language access, right? So there are certain times and certain procedures and certain interactions that require or are best suited to certain types of language assistance and that promote language acceptance, like we were talking about at the beginning, right? So I think that we can apply patient-centered outcomes research to language assistance in ways that really allow us to understand and leverage both the skills that we have within hospitals and also understand how to distribute, right, those skills across the continuum of care and across the different kinds of interactions that patients have. One of the hallmarks of patient-centered outcomes research is the inclusion of patients in the research itself, right? And that I think is a very unique approach and could really take language access research into uncharted territory and asking very exciting questions. What's important to patients, right? What do they want? What does a patient think in terms of how they interact, and how does language shape their encounter? And that's what we've seen in all of these stories, right? So, in moving forward in language access research, I'm really looking forward to using these models to bring patients in to asking the research questions, right? Not simply being subjects of research, but also being participants, right? So that's kind of the future of where this is taking me. So we can open it to a discussion now. We have about 10 minutes or so about training and the things that you're doing. So I know that many of you are working with on projects. I think we need to really get out of the mode in which Spanish or medical Spanish is, this course that students take and that's it, they're ready. It's not. It's something we need to think about across the educational continuum. Yeah.
I guess there are so many things here. You could be here for 2 days. But I have two very different questions. One is for our training. What is happening with us at UMass? At UMass, we started making that certificate program because there were nursing students who wanted to minor, just to develop their language skills. And then we had to kind of fit them, and they have a very heavy schedule too.
Yeah.
Like, do you really need to take Spanish literature of the 20th century or colonial Latin American literature? Do you need these requirements for the nurses? So we created a totally different program for them, still based on the minor. They still have to take one culture class, whatever it is, the medical Spanish. Then they take, but that's about it. Because these nurses do not have time in their schedules. They have to be in rotations and in this and in that and the other. Like, I would love them to go abroad, and there are now more study abroad programs with health related fields and with internships, and we are looking into those things too. It makes perfect sense, the argument that you're making of integrating both, but at least at UMass, the professional school does not give them the time.
I think that's a great question. So how do you actually pursue this integration? And you need to, one, have more intimate collaboration with clinicians, right? So one thing that I found in the graduate nursing program is just as tight, just as impenetrable as the undergraduate, right? So, nursing programs are infamous for being so packed because of accreditation and because of, licensing and so forth. What we've done at the graduate level is say, okay, you need 40 credits of clinical hours. Well, why can't 5 of those be clinical practice in Spanish, right? And then you begin interacting with clinicians. So I'm not capable of directing a clinical class, right? But you work with a clinician, and the clinician is directing the clinical, skills, and I'm looking at the language skills, right? So it's this really embedded collaboration between the two schools, and you need to get buy-in, but you can do it. It can be, and I think that's what nursing schools and professional schools can be persuaded to do. We're not saying, okay, add on another 12 didactic hours to an already packed curriculum. We're saying, let's combine 2 GE classes with 1 additional class and have this experience out in Holyoke, right? that will count both as Spanish and as clinical credit at the same time, right? Yeah.
Also, medical and nurse schools should promote already bilingual speakers with lower tuitions to be able to access to medical school, nurse school. They already know what languages, but sometimes they don't have the resources to apply to these schools. So that should be another way to guarantee access.
Building the pipeline has always been, how do we widen the pipeline of bilinguals into the medical professions? Yeah.
Why only physicians, or the pyramid that you show?
Yeah.
The higher the pyramid, the less bilingual skills, because only they have the access to these type of careers.
Yeah, you're exactly right. So why can't we think of pathways for medical assistants to ascend to physicians, right? Why can't we think of pathways to get Latino high school students with advanced proficiency in Spanish? Why can't we make them interpreters have them certified interpreters upon graduation from high school, work their way through a health degree in college as an interpreter, and then move on to become a, become a physician. So I think that there are pipeline issues, and we can view language skills as the catalyst, towards that pipeline.
The crazy question for me is you have such brilliant students working for you at Pan American. It's full of Spanish. What happens? The doctors, the McAllen kids end up working in San Antonio once they become doctors?
In the past, the McAllen kids just weren't getting in, so traditionally, these are bright kids, and what we showed with the program. So at Pan American, we developed a minor in Spanish. We called it Medical Spanish for Heritage Learners, similar to the same issues you were finding, right? Students wanted to minor in Spanish, and they were majoring in nursing and medicine and so forth. So we created that minor. And we did some analysis. We were funded by the Department of Education, so we had to do some analysis and figure out, okay, what's the impact? So we looked at language development, and we found that students were developing at a very accelerated rate. They were able to do things with language that they weren't able to do before. So we were doing the pre and post. But we also looked at other things. We looked at science GPA. So what impact does studying Spanish in the health professions have on your GPA in biochemistry, organic chemistry, and anatomy and physiology, right? And we looked at these courses, and we compared the grade point averages, and we found that students who had taken medical Spanish raised their grade point average by 0.2 grade points. Right? So they had higher grade point averages in science because they were taking, connected to these courses in medical Spanish. Now, why would that be? Well, in part because we're responding to an interest, right? We are cultivating an interest, and now organic chemistry is connected to other things, right? It's connected to, another set of vocabulary, another set of interests, another direction, and so forth. So we found that, and then we looked also at MCAT scores. And we found that students who were in the program had improved MCAT scores, particularly in the verbal area. Yeah, it's a GRE it's your medical school entrance exam, right? So we found that it also contributed to that, right? So but yeah, I think that it's doing this kind of work is also contributing to the pipeline, right? And also providing greater success for students to become the physicians of tomorrow, and with this kind of knowledge, right? With this, if you make a video like that, you have to learn something, right? And you have to have sort of this perspective on the role of language, right, in healthcare that otherwise wouldn't be there. You certainly wouldn't get it in your traditional medical Spanish textbook, right? Yeah. So, other comments? I'd like to know what you're doing in terms of Spanish in the health profession. So you're in New Hampshire or in Boston College and other places that are, what's going on there in terms of how you're developing coursework?
Because the things you were talking about the schedule for the nursing program, it was really difficult to find like a room for Spanish courses per se. So this is why we created this minor in Spanish and nursing program.
Yeah.
So it's just it's a new one. Yeah.
Yeah.
We couldn't figure out what to do, and their interest is high, and so we are starting a new program.
That's great.
These classes. Yeah, and there is another component that is just internship or some like I don't know, practicing in Costa Rica as well for months in the summer. So it's very appealing for the students too.
Yeah, yeah, and you know that again is the importance of thinking across the development. So study abroad, you know, it's not possible once you're in the nursing program, but maybe you can think about it before, right? So you know, normally the students will apply to a nursing program and they enter when they're a junior, right? They enter into the nursing program. They're doing pre-nursing before that, but why not target the students before that? So all the pre-nurse, let's have a pre-nursing program to Costa Rica, you know, that kind of thing.
They start as freshmen.
Really? Yeah. Yeah. Yeah, but I think if we think across the spectrum of training, we can really find these opportunities to enrich it. Everything doesn't have to be in a semester. Everything doesn't have to be in a year. You know, it can be spread out. You know, across the.
The other thing is we have students in psychology, public health, nutrition, kinesiology. All these students are interested in our program.
Yeah.
So in some way we will have to change things with
Yeah. Yeah. What about at Boston College? What's going on?
You have a as far as